everyone, and welcome to MG Matters 2.0, a part of the Rare Disease Connect in Neurology. I'm Pushpa Narayanaswami, and here we discuss lots of things that matter in MG. And I'm delighted today to welcome Dr. Freimer, a really good friend and colleague, a professor of neurology from Ohio State University, who's here today. And she's going to tell us some things about this really cool title, Are We Okay with Okay? And so we first have to define okay. But before that, I'd like to welcome Miriam. Miriam, thank you for being here today.
Pushpa, thank you very much for having me.
So tell me about yourself a little bit.
So I have been practicing neurology for over 35 years. And I have been spending most of my time with patients with myasthenia gravis, especially over the past 20 years.
Yeah. And I think that's so important for the context of what we're doing here, because we've seen myasthenia gravis evolve in so many directions. But are we there? Are we at the holy grail? Or do you think we've got ways to go? Are there things we could do better?
Well, I think it's really exciting how much things have changed in the past 30 years, going from having maybe one or two potential treatments, being able to do many different clinical trials with medications that take very different approaches to the treatment of myasthenia. We've also seen the development of accepted metrics to assess patients with myasthenia, which I think really helps us as a community start to assess what we're doing right and wrong for our patients.
Right. Yeah. And I think you sort of bring up a couple of issues here that I'd like to probe a little deeper in terms of diagnosis. Do you think we've got exciting advances in diagnosis? You talked about treatment and monitoring. How about diagnostics?
Well, I think from a diagnostic standpoint, things have definitely changed a lot. When I started off, there weren't labs that routinely did antibody testing. Where I trained, there were really no commercial labs initially. And so over time, we've seen that there are now many options in terms of commercial labs that do testing. And then in the mid-1990s, MuSK antibody was discovered or was described, and all of a sudden a portion of our patients who were antibody negative were found to be MuSK antibody positive, and we started to see that that was a whole new subgroup of myasthenia with slightly different kinds of symptoms, and maybe they responded to treatments differently, and we could start to understand that.
I'm going to go back to our original question. Are we okay?
Well, I think that that's a really good question, because what does it mean to be okay?
That's exactly
it. And how do you define okay? So maybe if we go back to when I started my training in the 1980s, maybe we are okay because we're a lot farther along.
Yeah.
But if you look in the 2020s, we're not okay because we still have a long way to go. We still have patients who we may have difficulties making a diagnosis. I think we need to do better. We need to understand more about biomarkers and what that means. And so from a diagnostic standpoint, we still have a ways to go. And fortunately, there are people who are working in basic science labs looking at that and who will help improve that over time. From the standpoint of medication, again, if we dial back 30 years, we're kind of okay because we do better than we did then. We now have new potential treatments that may minimize certain side effects that we associate with the old treatments. But there are still patients who are not doing really well, even with some of the newer therapies, or they still need those new therapies along with old therapies that have side effects. So I think it's really exciting because there are people doing basic science research about other underlying mechanisms of autoimmune disease and myasthenia in particular that may lead us to different therapies, different approaches than we know right now.
You alluded to the biomarkers or better diagnostic markers, but I think we also need some prognostic markers, and we'll jump there in a minute. But before that, I just wanted to mention, sort of second what you said about the treatment. There was a time when we did not have a choice except to accept the adverse effects because we had to treat the disease. And I think the exciting thing now is that we do have a choice. we have choices where we can say, well, this patient's got hypertension, or this patient has something else, or this patient cannot get drug A, let's give them drug B. So we have choices, and I think that makes it powerful.
What's really exciting is that there are different ways to administer
Yeah.
those medications.
Yeah.
It used to always be doing an IV or taking it by mouth. Now there are medications that can be administered subcutaneously into the skin. In terms of timing of medication, there are medications that a patient can administer themselves every day, or a patient can go to an infusion center once every couple of months, or even better, sometimes have somebody come to their house and do it.
And in option lies control, right? I mean, they have some control over that disease.
And that probably makes a big difference in terms of, are we okay with okay?
Yeah. You get to this beautiful point where you're saying, now that they have some control, we may have other ways of deciding what okay is. We may be able to go beyond, do I have double vision, or, am I able to chew to how's my quality of life? Am I able to go there and play a game of tennis? Can I travel? Despite the fact that I'm on these medications, how do I travel? Am I supposed to go to an infusion center every day? Exactly what you said.
That is huge. I have patients who go south from the frigid north every winter. Well, how am I going to get my medication? And now we have ways to do that for patients.
And you mentioned this, sort of having tools that standardize the measurement of outcomes over time and in between clinicians, if you will, and certainly in the trial setting. Where do you think that these are going? What do you think are the limitations of these? And talk about the prognostic biomarker in respect to the outcome measures that we use.
So let's take a step back for a second. Traditionally, neurologists, particularly neuromuscular physicians, are trained to do MRC testing, where you're giving it an exact number for somebody's strength. And the thing that I've learned is that there's a lot of inconsistencies there.
Absolutely.
So do you follow the muscle strength that we're trained to do, and is it the same person doing it every time? And in a patient with myasthenia, what you test at 0 point might be a little bit different than what you might see 5 or 10 minutes later if they've been active. So those are very useful for me as an internal control, but they're not useful for other people looking at it and for us to get a long-term evaluation. The problem with them is that, with the exception of MG-ADL, which is a patient-centered questionnaire, the other ones take time to do. And so how much ability do you have to do that in your clinic setting when you have a very limited time frame with a patient? Do you have other people who can administer it? And unfortunately, most of us don't. And so the other MG metrics are probably more useful in a research setting. So I think we have to use MG-ADL and our physical exam to try to assess that. There's also the MG quality of life scale, and I find that sometimes there are inconsistencies between that and ADL because other things go into it. What's going on in somebody's life? Do they have little kids that they have to get to school? Do they have to prepare meals? Do they have to do the laundry for the whole family? Do they have back pain?
Absolutely.
So they definitely impact how we assess patients on a regular basis. And so I think you have to use them all together. Are there going to be other biomarkers? And for example, in multiple sclerosis, they can follow patients with MRIs of the brain and the spinal cord. And we just don't have that yet. And will we at some point? Hopefully, because I think that will be much more helpful in truly following the course of a patient.
Going back to your comments about the outcome measurement, absolutely. I find the quality of life measures are useful to get an overall sense of how the patient is doing, but not necessarily an overall sense of how the disease is doing. I'm going to end and ask you again if you agree with this. I think we are okay-ish, but we're not okay quite yet. We've got ways to go. How about that?
I love that qualification of the ish. And the reality is, this is why we keep doing this, is because we want to make it better. And it has been cool. The trajectory is clearly going that direction, but it's never good enough.
Absolutely.
So.
Yeah. Thank you. Miriam, thank you so much for being here. It was always fun to talk to you, you know. I think this evening we got to go get that drink.
Okay. All right. That sounds great.